Tyler Hardie. I'm a medical student in the University of South Dakota. Today I'll be talking about, does virtual reality improve the wide awake surgical experience? So this talk is kind of building on Michaela's talk on the wide awake local anesthesia, no tourniquet talk, with adding the virtual reality component. So I have no disclosures. So the goal of today's talk is to talk about virtual reality or VR, why use it, whether it works by looking at the literature, and then looking at applications in other specialties besides just ortho and hand surgery, and then our own experience as a little QI project in South Dakota working with VR. And then just finish up talking about where some future directions could go. So why use wide awake hand surgery? Well, in short, because of the anxious patient, to provide a distraction prior to undergoing wide awake local anesthesia, wide awake surgery. Because as over the last 2 decades, VR has been explored as a resource to enhance patient care in the medical setting as a distraction therapy for pain and anxiety. And so with wide awake surgery, there's often is that anxious patient who just can't fathom going under surgery wide awake. And so traditionally, as Michaela mentioned, they don't want to do that. Plan B, put them under general anesthesia. But we suggest that the new Plan B involve procedure room, wide awake surgery, and then add VR as a way to optimize the patient experience and help with anxiety. So a little bit about pre-op anxiety in adults. The incidence has been reported to be 11 to as high as 80%, with risk factors including smoking, psychiatric disorders, depression, among other things listed here. May also require increased intra-op anesthesia, and post-op pain control can be a challenge with anxiety in the adult patient population. So these studies just have shown just how prevalent anxiety is in the adult population before surgery, and the importance of identifying it in this vulnerable population to ultimately reduce undesirable surgical outcomes. So the next few slides, we'll take a look specifically at VR and wide awake hand surgery. This one here is by Dr. Clarkson out of Michigan State. He's a leader in the virtual reality world, having developed his own VR headset, the one we actually use in our clinic. And in this study, we found that in patients with VR compared to no VR in wide awake hand surgery, patients exhibited lower anxiety scores during injection, during procedure, and at the end of the procedure, as evidenced here by the figure on the left. Patients also reported that they felt the experience helped them to relax and that they would recommend VR to others. This next study out of the Journal of Hand Surgery involving 15 patients really just gives insight into the patient's thought process regarding wide awake hand surgery. While all initially had concerns about having wide awake surgery, 13 of them specifically expressing concern that they would not wanting to see the actual surgery. All of them actually were open to the idea of wide awake hand surgery, given that there could be a distraction involved, such as a video headset, audio, etc. And I think this just really demonstrates the effect that VR can shift the mindset of patients towards being open and going ahead with this wide awake procedure, despite maybe having some initial reservations. This one is a multi-center VA study, looked at pre-op anxiety scores and vital signs, revealed reduced anxiety in the VR group, also contributed to the patient's perioperative satisfaction, with a statistically significant drop in the anxiety score as demonstrated here. Secondarily, this study found that VR could also provide doctors with a better focus on learners and med students and residents, improving the teaching experience. I think just because the patient's awake, aware of the surgery, the surgeon is talking about the anatomy, really being more involved and proactive with the teaching aspect of that too. So that was another cool thing that they found. Some current applications of VR and other specialties outside of hands. Actually, interestingly enough, VR has been used as an adjunct to spinal anesthesia for total joints. And it found that appeared to be well tolerated and associated with less intraoperative sedative medication usage than spinal anesthesia alone, specifically when it came to intrapropofol sedation, showed here. Here are a couple of reviews that have been done on the topic as a whole. The general consensus is that VR can be done feasibly to enhance the patient experience by attenuating subjective perceptions of procedural anxiety and pain. However, there are some inconsistent findings among the studies, and concluded that further randomized control trials are required to truly elucidate the effect VR can have on aspects such as objective measures with vital signs, and then within the context of acute care. Here's a study changing gears a little bit, post-operatively helping with VR as a non-pharmacological modality for pain. Also, in the pediatric population, it's been shown to help improve kids with cancer in the burn unit, and then with minor pediatric plastic hand surgeries, or just plastic surgery. And I think this is a spot that it can really be helpful with kids, just because they're so well attuned to technology as it is. So I think they'd be really would like VR. So also, VR has been shown to help in oral surgery and phantom limb pain. There's some other interesting applications. So going into our experience with wide awake surgery using VR, it's done at the Sanford Orthopaedic and Sports Medicine Center in Sioux Falls, South Dakota. It's a QI project involving 30 patients over the last year, and using the wide awake virtual reality headset. Here, like Michaela's presentation, there's the procedure room that we use. Here's a patient using the virtual reality headset while having surgery. And then these patients were evaluated preoperatively with a questionnaire. They were asked about anxiety pre-op, intra-op, and post-op, and then how much fun they had during the case on a 0 to 10 rating. Here's an example of the questionnaire we used. Also asked the patient GAD-7 and a PHQ-9, along with vital signs. Here's a way you can easily obtain the GAD-7 and PHQ-9 on MedCalc. So here's the headset with the iPad that you can use with the various applications. Here's a list of them the patients can choose from. A fan favorite is the space exploration segments. But yeah, they can choose among any of these, ranging from a couple minutes to 20 minutes. And next is a little example of what they see when they put on the headset.
So you chose to use Wayland. Great choice.
In a moment, I will be cleaning your hands with alcohol.
In this fashion, I'll be along the way and it's so come.
Over the next couple of minutes, we'd like to talk to you about what you can expect over the next 2 weeks of your postoperative care.
Dr. Vandermark, I think you said one patient.
When I first walked in, and I looked around and I thought, it's actually not as big as I imagined on television. The White House is the people's house, and Michelle and I always joke, we're just writers here.
The one that's just going to space for the dangerous trip like we used to, not only live here.
And we're not everything is really the quicker you know what the surgery is.
That power of adaptation is one of the most beautiful aspects of the human life.
You have to be able to relax, but there always has to be part of you that's ready to serve. When you see everything together now, you get this profound sense that the world is small, we are all reliant on one another, and we're all in this together.
Yeah, Dr. Vandermark mentioned that one patient loved it so much that the surgery was over and he still wanted to keep watching this program. So, yeah, on the space station. So a little bit with our data, with the 30 patients, average age was 52 years, predominantly female. All patients enjoyed the BR video. Most common procedure performed was a carpal tunnel release followed by trigger finger. An average pre-op anxiety score for our patients was 5.4, which you can see dipped to 2.1 post-op. And then with pre-op heart rate, intra-op heart rate, post-op heart rate remained pretty stable, which kind of reflects the overall consensus in the literature that it doesn't do a whole lot in that realm, or that further studies are needed in that regard. So whether or not our patients found that the video was enjoyable, and 100% on that. Fun rating was average or a range of 3 to 10, with the median being 9. So for future research, it's imperative to have a simple yet effective preoperative screening tool to identify the anxiety in these patients before surgery, and then to implement a practical workflow, just so that it can be integrated without prolonging the time with everything else. So here are a few examples of screening tools that are out there right now. This is called the FAS scale. Uses validated single item faces anxiety scale, particularly useful in the settings where fast and precise screening is necessary. Here's the Amsterdam screening tool. It's another valid, reliable, and easily applicable instrument for assessing the level of patient's preoperative anxiety. And then finally here, and what could potentially be the unicorn of screening tools, is the computerized adaptive screening tool, or CAT testing for short, which is a rapid, precise, and accurate assessment tool of numerous mental health disorders, including anxiety and depression, which can be administered without the need of a trained interviewer. And an example of what one of these are is PROMIS, which stands for Patient Reported Outcomes Measurement Information System. So this is readily available online and can be easily integrated into the administrative interface. So I played around with it and it's actually pretty effective. So in summary, VR does improve the wide-awake surgical experience. It's well received by patients. It decreases anxiety, patients enjoy it, they have fun. Importantly, there's no sedation and there's cost savings associated with wide-awake surgery. Workflow is acceptable, and future research could involve perhaps a more streamlined preoperative screening tool, perhaps even that CAT method that I talked about. So I'd like to thank Dr. Vandermark and staff at Sanford for all the help in this project. So thank you.
Thank you. Are there any questions for?
Yeah, does it come in a less bulky kind of a thing? I remember going to the dentist one time and they had a slim, almost like a goggle device.
Yeah, they're working on that.
Yeah, because I'm thinking for like spinal injection, that's going to get in the way.
And they're also working on a set of headphones
Integrated.
completely isolate the patient.
I think they can pass
What do you do to keep patients from bodily participating in what they're watching?
You know, we haven't had a problem.
What?
We haven't had that problem.
Ever had that problem? I mean, if you're going down a
Surprise.
ski slope and somebody wants to lean this way,
You know, we don't do the ski slopes. So
yeah, but I mean, people do that.
I have not had experience.
They're just gonna lay there.
Some ways still.
not-
Most are pretty screwed
Not
up.
participating in what they're watching.
Yeah.
Wow.
Well, thanks for the University of South Dakota. Thank you.
Thank you.
So our next speaker is Cristian
Gragnaniello.
Very good, thank you. And he's visiting from San Antonio, Texas, and he's going to speak to us on minimally invasive treatment of severe thoracolumbar trauma. Thank you.
Well, thank you for having me again. Last year was amazing
and it was so good that I decided to come back. So we're going to talk today about some of the, a little bit about a different way or same way of looking at trauma. As you know, anything I do, I always ask myself, what's the possible thing I can do that I think it's going to work? And so we'll see a little bit what's going on in the literature, and I'll show you a couple of cases. I have some disclosures that are not relevant to this talk. And so just because of what I said, I'm always looking at learning more. I think this is a lifelong learning career that we all have, and we ought to change, learn, and improve so that we can be better for our patients. And it looks like doing a literature search about minimal invasive spine surgery and trauma, especially in the thoracolumbar spine, there's been some interest over the last about probably 15 years. I'd say there are about 4,000 articles out there, and people came up with different treatment paradigms so that we can choose the right operation in the right patient. And some of the best spine surgeons in the States have come up with different things, and you can see here that this is a decision tree that it's very reasonable. Where bottom line, if you don't, if you need anterior column support, you may just have to do a corpectomy of some sort. Otherwise, you can get away with percutaneous screws and so on and so forth. And these are some cases, and this is, I think, done very elegantly, and you can save a lot of blood loss and pain to patients, shorten their stay, get them back up faster for those who are lucky to preserve neurological function. And again, this became very popular, and it still is, and I think rightfully so, especially now that we do a lot of lateral surgery with oblique technique, straight transpsoas. Now, lots of people are doing prone lateral, and again, other trees that essentially really point to the fact that you can now certainly demonstrate that percutaneous screw fixation in certain type of fractures, especially AOA and some of the B's, it's maybe enough. And then if you need anterior column support, you might have to do something else, and you can also do it minimally invasive. Other authors have demonstrated that there's not much difference in the kind of correction that you can achieve with open or percutaneous screws, and you don't lose that correction afterward. We've seen in a minute there may be some trick to percutaneous, but mostly you don't really lose anything meaningful for this type of corrections. And as we go forward, other people then they've tried to different things. So you can essentially look at a fracture and say, okay, I'm going to have to do this plus this plus this, and this is a very interesting article where you see AO 0 to 2 and 3, 4, B and C treated differently, and this is essentially what they do. They look at the fracture and the fracture pattern, and then they say, okay, I can do this minimally invasive from the back and add plus or minus adding a second stage or same stage anterior or lateral. All that we said, works kind of well in the U.S. If you move outside of the U.S., obviously regionally, it's difficult to get some of the percutaneous screws and things that cost more. So it's a little bit limiting to really have a feel around the world. But some of the authors have tried also thoracoscopic, surgery for bursts that happen at the junction and the lower thoracic spine, and that's also been an interesting experience. I don't have that experience myself, but it's very interesting. And again, so this is one of the initial paradigms that came out in 2014. So you're looking at ethylene score that we're more familiar with here in the US and say, okay, it's more than 4, I can do open posterior, or I can do an MI, combination MIS anterior lateral with a corpectomy plus a posterior percutaneous instrumentation or open. And this is one of the cases that they showed. I think it's obviously very elegantly done. One of the things that's being codified, and I think it's great, and I do it, and my partners do it all the time, is just to do percutaneous screws in most of the patients with ankylosing spondylitis. I can remember last time I've done one open, even long segment. This is an interesting one that applies to all open versus MIS surgery. How much muscle units you can spare by doing just percutaneous screw fixation. Other interesting concepts have been coming in the last decade is the use of not using essentially using screws that are they don't rotate, they have a fixed head, and so that you can actually manipulate the vertebra to obtain a certain type of correction. Obviously, it takes some time to get used, and especially when you have residents around to understand, let them understand how they really need to line up. Otherwise, having a head that moves makes it very difficult to achieve any correction. But you can now, and this is something I do often, to put a shorter screw just in the pedicle of the fractured vertebra and use that to leverage to my advantage to get correction and regain, go from a kyphosis back into a lordosis for the anterior column. And there are other papers that they've shown the use of monoaxial screws to do so. Now it's interesting how people are taking this and to the next level, doing percutaneous screws and MIS decompressions of the segment. You can see here the P on the right. There's a bone fragment that they're looking at the scope and then tamping back in. I mean, I've never done that. Honestly, I'd be a little worried that I think it's probably technical of me not to be able to really embrace this. It's very interesting. When we do thoracolumbar spine and do log segments that are percutaneous, especially if you have multiple fractures, you really need to pay attention to the heat and blood loss from just placing screws. Sometimes this is best controlled open. And now, just like Dr. Zamorano was showing you guys beautiful things yesterday with the endoscope, people have taken that and started doing traumas with the endoscope. I think that's probably what the next generation will do. Before I retire, I'll learn some of that. But what happens when we have catastrophic trauma? Is there anything we can do for cases like this? This is a case report from somebody else. And we're looking at thoracic spondyloptosis. So for the students in the room of spondyloptosis, when a vertebral segment is completely over another one, so more than 100%. And so you see, this is a different scenario. This is a different image that you see. Essentially, for those that, for the students, essentially they're using these clamps to catch the spinous processes and try to pull in the line. And so you can imagine there are a few problems here. One is you see the pool of blood on the left. There's a lot of blood loss. It's difficult to think about saving function. Not that all of these patients come with any function, but for those who do, you're gonna deal with CSF, spinal cord, nerve roots, and blood loss up front. So these are all issues that I can see with these. But great corrections can be achieved. That's almost, if you look at the panel in the middle, that's almost near-anatomical. The AO is classified, these type C injuries, the fracture dislocations, and give us some advice on what to do in different. Actually, this is a very interesting paper. You never see the AO spine tell you this is how you do it, because this is how difficult and tragic these injuries are when they come in the middle of the night. And so you can distract and pull, just like we saw. For lateral, you can put actually an horizontal rod and distract and hook the right shows you how you can actually manipulate rods and towers as well. And so this is one of the two cases I'm going to show you just to show you how I started thinking about this again. The idea is what's the most smallest possible thing I can do that it's going to work. And so this is an unfortunate gentleman that came in the middle of the night after a high-speed crash on his motorcycle. He was alive, but he had a terrible injury that I'm going to show you with paraplegia, no rectal tone, and had some sensation kind of in one leg. And so this is the scan. So it's kind of a tough injury to treat, especially because this is really in the middle of the chest. Not many options here to go around. And so what are you going to do? This is obviously a catastrophic MRI. So I thought that, we can do what a lot of people have done before and try and put a cob in there. So open it all up, take ribs on both sides, and try and make this very mobile and try and pull it over. This involves like about 4 vertebrae, so it's really difficult to say, okay, I'm going to just pull on spinous processes or do anything like that. So, but I looked at this scan really hard, and I thought, I think I can capture pedicle in that T6 and probably get something in T8 for sure, and one on T7. I said, maybe I can use one of those rails, distraction rails, and just pull it, so I don't have to deal with CSF, spinal cord, nerve roots, CSF, all the whole things. And so that's what we did, and this is an intraoperative picture of this system after we placed the screws. So again, we said earlier, the screws that we placed, they're not multi-axial, they're monoaxial in the levels of the fraction and above and below. So at this point, we started distracting on this until it actually, this is a view from the top. You can see how some vertebrae are here and the other ones are here, the spinous processes. You see the supraspinous ligaments really far away. Until this actually completely gave, and I thought, okay, I broke the spine. It was already broken, I made it worse. I don't know what happened. And it actually is because it kind of realigned. So this is what we got at the end. We were super happy with that. So we finished the operation and instrumented. We actually opened the laminectomy, made sure everything was okay. Somehow the dura was intact, and so we didn't have to do anything with that. And these are the angles and the measurements, so I won't bore you with that, but we were pretty happy with that. I don't know how, somehow the patient 6 months later now is actually moving his right leg. And he had some sensation, that's all he had. But now he's kind of almost full strength in that leg. I can't explain it, obviously. But that's how we thought about that case. And this is another case, far less complex, but that poses a different question, a question of anterior column support, which I was telling you, a lot of people stress how important it is to reconstruct that. And I think it's just, I think it's probably, Professor Welch will tell us, it's probably case-based. You need to choose your patients wisely, and that's the whole of spine surgery to me. So we had this a lady that was trying to get Christmas decorations, as it always happened about that time of year. She actually fell through the ceiling, and she came and had this injury, and she had a complete burst with severe comminution, but she was actually neurologically intact. This is her CT scan. They show some of the the features that make this a very difficult injury to treat. So she has 70% of height loss. The fragment is trapezoidal, which is one of the the teachings that say, okay, this is not going to push back when you distract on this. At least that's what we think, and it's highly comminuted. So all sorts of reasons why we should go anterior. And but I did a similar operation to the one I showed you before, percutaneous this time. And because one of the pedicles was involved, and I wanted to see how much correction I could get, because if it was a super healthy woman going to yoga, very fit, I'm like, let me see how much distraction I can get. So I got this on the table. I'm like, maybe I'll just leave her alone. And I braced her, and she remained intact, thankfully. This is the immediate post-op. And correction 6 months later. I thought I was very happy with that. I didn't, I decided, you can always do more and go back and do second operation and do a corpectomy from the side or do something else. But, this one didn't take long. She didn't lose blood. I think it was something obviously we got lucky, but something to think about. Well, thank you for having me again. Questions?
It looks like you got ligamentotaxis to bring those fractured fragments back into position on your last image.
Yes.
So that looks really good. Good job.
Yeah.
Just want to comment how positive your moral approach is. You do as little as you can do to get the best possible result. But I do want to say, our trauma guys present similar findings. The guys get great results on young, healthy people. And I really love the fact that you showed the 6-month x-rays. Many of these patients, especially the trauma group, they get lost and they never get seen again, but they do show up in other hospitals with pseudoarthroses, just because it's been such a minimal degree of purchase and a minimal degree of bone laid down. So I just try to remind the residents, this probably works quite good in the selected patient population. You use it on even that 63-year-old. I'm surprised, but this is, you said, a healthy,
yes,
very healthy woman. Most of the degenerative condition or patients that are older and have degenerative changes, in my experience, they don't get fusions like this unless you really go out of your way to get a fusion with a lot of bone.
Absolutely.
In that same patient, the trapezoidal fragment that's in the canal, the 63-year-old, do you find if you image them later on that you get some bone reabsorption of that fragment itself?
Well, I haven't had a CT yet because she says 6 months. I usually CT everybody at 1 year.
Okay.
So it's to be continued.
But have you seen that in the past as well?
Well, I need to say that it's kind of a mixed group.
Okay.
I mean, probably older and female and, kind of osteopenic, yes, absolutely. And I think I wouldn't have done it to begin with, but yes, I've been surprised both ways.
Yeah, I'm just curious, radiographically what the canal looks like a year down the road. That's what I'm saying, yeah. That's what I'm saying, so I think you almost get some sort of quasi-resorption as well as, yeah. It also looks like a fracture.
On this percutaneous case, did you put some bone around or?
Which one? This?
Well,
This one was just purely perk, so no bone.
No bone.
And this one, yes, in this, yes, I'm actually looking for a fusion there, so yes.
Can I ask you one question? When the patients come with an injury after a traumatic fracture, and you see them and we examine them, we always say the canal is narrowed. If we decompress the canal, we get more room. Frequently, and that'll improve the patient. Frequently, it doesn't. Has the damage been done in the instant of the injury, or is the damage ongoing because of the narrowing, or both, in your opinion?
So I think it's both, and I think that's a great question, and I see those patients that don't get better, and that's what makes me think, because when I'm on call, I try and take them ultra early, especially if it's severe injury, like an hour or two. And I had a patient, now she's 2 years post-op, and she's regaining function. And we decompressed the canal, and I don't think I've ever seen a swollen cord more than that. I mean, she's was exploding, and she was down within 2 hours, and eventually she got better. And other people, they just don't. And I feel the worst ones are the cervical injuries. I feel it's not a good. The literature says that you go from A to C in 20%. Maybe I think if you're talking cervical, way less.
Thank you.
Thank you very much. All right, we have anterior exposure to the lumbar spine. Yep. Visiting from Houston, Texas.
slideshow at the top.
At the top? Okay.
Oh, there.
Thanks. All right, well, thanks for having me here this morning. I'm going to talk a little bit about anterior approaches to the lumbosacral spine, although this can be extrapolated to the thoracic spine as well, which we do a lot of that as well. So I don't have any disclosures. And like I said, this is going to be primarily limited to the lumbosacral spine, and predominantly involves A-leaf and artificial disc implantations. To really talk about this area, the most important thing to talk about is really the anatomy. And I mean, I've been in practice 23 years, and this isn't something that as a cardiac or vascular surgeon 20 years ago we were really taught. So a lot of this I learned by scrubbing with spine surgeons and kind of trying to perfect the way that we get down to the lumbosacral spine. So I have some tricks and things that I've gotten in trouble with in the past. So usually we'll be able to do L5S1 approach to an incision about this big. Once we start getting up to, you know, if we're doing L4 or 5, L5-1 or S1, I'll usually take the incision up to the umbilicus. So if I'm doing 5-1, we'll do the incision here, and if we're going up above to 4-5, we'll take the incision up around the umbilicus. Sometimes the way that 4 or 5 lays, you can get it to it with that lower incision, but oftentimes you need to extend it up a little bit higher, as you'll see. I think one of the most important things to talk about is really how do you get down there, because when you start doing these, it seems kind of not completely obvious how we approach the LS to get down there really quickly. And so what we'll do is we'll make our incision in the midline. Sometimes people will have old incisions, and we'll use those and kind of elevate a skin flap. I don't really like doing that oftentimes because I worry about the vascularization of the scar, but the most important thing really is how we get through to the rectus sheath. So we'll make our incision in the midline, come down to the rectus muscle, and then we'll go out laterally. And as you develop out laterally, you can see that the aponeurosis kind of opens up for you. And the first thing that we'll look for as we start developing the retrocranial space is the psoas muscle. The psoas muscle is kind of your landmark. And then you'll see, once you see the psoas come in, you'll see the iliac vessels. So you'll see the iliac vessels come in, and you know, you want to be cognizant of the ureter, obviously. The iliac artery and vein are pretty obvious as well. I think the thing that people get in trouble with most, in my experience, is probably the vein. The artery, I mean, is pretty simple to repair. The vein sometimes can be a little bit challenging to repair. You have to remember that it's not as though it's right on you. You're in a deep hole, and a lot of the times, if you're doing this as in an ASC or an outpatient setting, although you may have cell saver and blood products available, you may not have all of the things at your disposal that you would have in a traditional OR. So I think the most important things is first identifying the structures. So you want to look for the median sacral artery and vein, which are going to need to be taken for L5S1. And then we'll always look for the iliolumbar vein that comes off right around here and tracks up along the spine itself. So again, you'll see the median sacral artery here and the iliolumbar vein. And I think the key to taking the iliolumbar vein is first identifying it, because in some people it can really tether the iliac vein, and if you pull on it too much and it starts tearing, it's a pain in the ass to get control of. So I'll oftentimes, or almost always, identify this, especially if we're going to go up to L4, L5, put some clips on. I usually double clip it here and double clip it here and then divide it, and that'll allow you to retract like I said, once it bleeds and starts retracting laterally, it is extremely difficult to find. So bleeding from the median sacral artery or vein is not a big deal. And when you fall down onto L5-S1, you'll see those pretty easily. You can put clips on it. It's really out here that you get in trouble. Again, the psoas muscle, you can see the spine coming in here. We're taking the median sacral artery and vein and L5-S1. And it's oftentimes when you're up at 4 or 5, like I said, that you have to take the iliolumbar. This is typically how it looks. I just kind of wanted to run through this because I know a lot of you are pretty familiar with this. So some of the complications we can see from this are ileus wound infection, retrograde ejaculation, and neurologic problems of pain and numbness. Surgical site infection is pretty uncommon, and infection of the implant is often also pretty uncommon, although it has been reported. Retrograde ejaculation is when semen enters the bladder instead of bleeding through the penis. A lot of this has been tracked back to injuries to the hypoglossal plexus. So in males, we'll oftentimes try not to use bovie in that area. In general, we'll try not to use bovie even in females too, because as you can imagine, when you're in this region, you're going to be manipulating the hypogastric plexus. You kind of can't get away from it, and it's often not all that obvious when you're doing so. In terms of retrograde ejaculation versus delayed ejaculation, again, both pretty much related to the hypogastric plexus. There are many medications that have been described to help treat the problem, but to be honest with you, the best treatment is to try to avoid it initially, to be cognizant of the hypoglossal plexus and to not use bovie. Again, there's to treat delayed ejaculation, there are many medications described. I won't bore you running through those. We know that in men, about 40% of patients have some change, but in females, the number's pretty much equivalent. About 40% of women report some changes in their menstrual cycles or other non-specific changes in their sexual activity. So again, even in women, although it's primarily described in men not using bovies during exposure, we try not to use it for women as well. So I guess I just wanted to run through it quickly.
Appreciate the fact that we're now seeing the vascular surgeons, as I mentioned before your talk, help us, because you guys are superb surgeons, and it's nice when you get a vascular injury. But having gotten the venous injuries with general surgeons, vascular and vascular surgeons, as soon as we get it, it's 6-unit blood loss.
It is.
It's 30 minutes, and I've never seen the vein saved, and all of our egos get in the way that I know that somehow I can reach in there and stitch it, they know somehow they can reach in there and stitch it. As it turns out, nobody can reach in there and stitch it. But I'm saying that meaning, if you get the vein injured, should we just take it?
No. So what I would say to you is that, first of all, that's why I wanted to really focus on the anatomic issues, because if you do it properly, you shouldn't be losing much blood, 50 cc's of blood loss. I mean, but when you do get into the vein, it's a pain in the ass, and it bleeds like crazy. And like we were talking about earlier, when we do it, we don't use we don't use an Omni, we don't use these big retractance systems. We use 3 Wileys and a Steinman pin that we put at the crux right around where the iliac artery and vein are. And the reason we do that is because you can control the tension that you put on the vessels. As we talked about before this talk, what'll happen sometimes is when you have a traction injury on the vein, you don't recognize it until you let up retraction. And when you do it, it's bleeding so much that everybody's finger is tight. So I think the time that you take to get everything retracted and the tension that you put on the vessels is key. I also think that when you, like I was kind of describing earlier, when you look down in this hole, it's oftentimes, some people wear loops, some people don't. I mean, I wear my loops, but you would think it'd be really easy to throw a stitch there, but it's kind of a similar concept of when we're doing lung surgery. To actually tie down in that hole can be challenging. So you'll see most people use clips, right? So when they clip, even when they've injured the vein, they'll try to clip off the vein. So if there's a hole in the vein, I'll try to put, you know, clips on both sides at an angle to the hole to close it. You'd asked me a little bit about endovascular treatment of venous injuries. Another option is to pack the patient, which that should temporize the bleeding from the venous side. Then you can get an access in the groin through the vein and put a covered stent in to seal that area. I mean, that's kind of a catastrophic type situation, but if you've got a big rent in the vein, that may be your only bailout, because I promise you, like you said, you'll lose 2, 3, 4 liters of blood looking around and screwing around with it.
Thank you very much. There's really, I'm not at an academic center, so there's a real need for approach surgeons for our procedures. And so, you want to move to Michigan?
Too cold for me.
Why do you think more people aren't willing
Well,
or interested in doing it?
I think it's, you know, I think it's kind of fun. It's like it's a fun procedure to do. Nobody trains us to do. I mean, you know, all these guys who you're using, they taught themselves. They may act like they, or someone taught them, you know, their senior partner or something took them through, because it's not something you traditionally learn. And to do it quickly and efficiently takes some practice. So you got to have some reps to do it. So.
You know, I not so jokingly, when the general surgeons or when the thoracic guys do it, they bring their fellows or the residents. I tell the residents, just look at what he's, you know, look at what he or she is doing. Remember how to do it, because you may be in practice somewhere. You may have a spine surgeon who wants you to do approaches. You have an instant job. If you can do that efficiently and effectively, and usually the cases go quite well, it's really not a huge time commitment. And you know, usually there's not a lot of post-op care if everything goes smoothly on behalf of the general surgeons or vascular surgeons.
Yeah, I completely agree.
It would be it's a great job. When I was in Wyoming, we had a surgeon up in Colorado. That's all he did. So we had like a bus, okay, that slept in and everything. No, seriously, because like, you know, he's not screaming at patients. When you've already selected,
Right.
There's really no post-op.
And if they're skinny, we love you even more. So.
Right. Well, a lot of it depends also on his reimbursement from the hospital, right?
Yeah.
So sometimes we would share a code, right? Or sometimes he would negotiate in the hospital and pay him. So.
Yeah, I think it's interesting because, you know, I'll get people who ask me to, some of the younger guys who ask me to, you know, show them how to do a few of them, and then we'll go out and do them. Because, like I said, it's not something we ever really were trained to do.
Just to your question about why is it that there's not too many general surgeons or vascular surgeons doing these things. One, ever since vascular got more into endovascular, most of the open exposures kind of quit being the norm for the vascular surgeon training. So you see a lot of the younger vascular surgeons now, they're super experts on the vascular procedures, but then when it comes down to open exposures, they kind of got a little frightened because they're not have not been exposed. So in order to mitigate some of that, the Society of Vascular Surgery has started to incorporate this in their curriculum. And there's a big effort on to try to come up with training programs, quality improvement measures to kind of mitigate some of the complications posed by this.
That's why I say we're doing more surgery as the population gets older. We're doing even more surgery. You know, if you stick around, a lot of different anterior approaches, retroperitoneal approaches and lateral approaches. I'm just recommending that people learn how to do it because we need them, and this is a job.
I think you make an excellent point. I think that we're so super specialized in cardiac. I mean, there are people who just do minimally invasive valves. There are people who just do endovascular, and that's all they do, and they can't do a AAA open anymore. So, I mean, we've kind of made our own bed in that regard.
Very good. What they very much, guys. So we're right at the 12 noon mark, but we have 2 talks left, and so we're going to press forward. We have Paolo Alimonti from Boston, and his postdoctoral research fellow at Brigham and Harvard Medical School. Thank you for addressing us.
Will be Gragnaniello.
And your talk notes work with Lucia Zavarano as well. Thank you very much.
All of the rotation with us,
I don't have it on
somebody
here.
goes to, yes.
So.
And we're just waiting for the organizer to close the corrected version of the presentation.
Any disclosures? You can save a little time.
None at the moment.
Okay. Skip
Yeah.
slide 1.
Yeah. So, David, thank you very much for the introduction. Good morning, everyone. So, I'm very happy to present my work related to the clinical and surgical management of cavernous sinus meningiomas, related specifically to the clinical guidelines versus the latest surgical perspectives. So, cavernous sinus meningiomas are a relatively uncommon and infrequent lesions that we encounter in the intracranial side. They do represent around 1% of all the intracranial tumors of the meningeal series, and they're mostly characterized with a rather benign histological behaviors. But nonetheless, it requires us to be very careful and differentiate other potential etiologies, especially related to other meningiomas extending from the petroclival regions, schwannomas, hemangiomas, and pituitary adenomas as well, also related to other possible etiologies with a more malignant behavior. So although the cavernous sinus meningiomas mostly have a benign molecular and cellular behavior, this doesn't mean that they are benign or that they are benign per se. So in fact, they lie extremely close to what Parkinson has described as the anatomical jewel box of the cavernous sinus, which is full of neurovascular structures which are critically important. So most oftentimes, cavernous sinus meningioma patients present with a multitude of single or combination of cranial nerve deficits of the cranial nerves coursing through the lateral wall of the sinus. They may also present with syndromic features, for instance, cavernous sinus syndrome or a Tolosa-Hahn syndrome presentation characterized by ophthalmoplegia and very painful, severe bilateral headaches. Or they may also present in a relatively rare amount with endocrine disturbances associated with the extension of the tumor and the
A couple of years back, Corniola and colleagues have presented with consensus guidelines on the clinical and surgical management of these lesions, and they have described the differences in the growth pattern of these tumors as related to the downstream clinical and surgical management for meningiomas. So you can see here that type 1 lesions are mostly associated with an inward growth towards the sinus, since they originate from the arachnoid granulations. And for these reasons, they tend to encase the intracavernous carotid artery and often involve the cranial nerve coursing in the lateral wall. For this reason, most of these tumors are not generally recommended for surgical treatment. They usually tend to be addressed with radiation therapy or some other treatment. On the other side, type 2 and type 3 lesions present with an outward growth. Type 2 tends to point up and outwards towards the anterior temporal pole. It doesn't generally result in a very severe displacement of the cranial nerves, and for this reason it's the one which is most suitable to the open craniectomy. While on the other side, type 3 lesions present an outward growth from the medial meningeal layer of the lateral wall of the sinus, and therefore they tend to spread and sort of displace the cranial nerves, and for this reason more medial approaches like the endoscopic endonasal surgical routes are much more indicated. Imaging is of course critically important for what concerns both the preoperative and the prognostic outlook for these patients. We know, for instance, that the CT scan sequences allow us to detect hyperostosis and calcifications, something surgeons want to be aware of, especially for the intraoperative management, as well as the perfusion CT scans, which give us the assessment of the patency of the intracarotid artery for further consideration of extracranial bypasses. MRI sequences enable us to study better the anatomical relationship of the tumor with the neurovascular structures, especially with the cranial nerves. And they also enable us to give us a little bit of an outcome of the tumor growth rate and the natural evolution of the disease. And for this reason, it's especially important for patients that present follow-up to tailor the treatment, downstream treatment accordingly. And in their work, Corniola and colleagues indeed have presented with guideline for the management, and they have reserved the surgical treatment for cavernous meningioma patients to those cases where patients are younger, they are symptomatic, maybe even rapidly symptomatic, but they nonetheless present with other general well patient status, and feature tumors which are relatively larger in size. So we're talking about around 2.5 centimeter in diameter minimum. All the other options, including patients that are older than 40, they present with not so good clinical status, they present with smaller tumors. They're usually addressed either conservatively for those patients that are not symptomatic, or with radiation treatment for those that are. And this was actually the case for one of the patients that we encountered in the clinic. So we got a 72-year-old male patient. He underwent resection of a posterior fossa tumor of undetermined histology in another country in his infancy. He presented at the MRI follow-up with this contrast enhancing lesion, which was consistent with the right cavernous sinus meningioma. He was recommended for gamma knife radiation treatment at the diagnosis, and he's been stable ever since. And this image sort of gives you another overview of the richness of the anatomy of the skull base, showing especially all the anatomical triangles that are encountered while trying to cross towards reaching the cavernous sinus. And as we have seen in the literature, most of the classical surgical approaches for cavernous sinus meningiomas in the open tackle the tumors from the anterior and the middle cranial fossa. Although there are some records in the literature concerning posterior approach, they nonetheless present a very long surgical corridor, and they are associated with more postoperative complications. And of course, each surgical approach crosses different surgical areas, different anatomical triangles, and for this reason, the specific postoperative deficits associated with the approach vary from one case to another. So, as we said, the surgical approaches are mostly concerned with the anterior and anterolateral skull base. These are the more classical approaches that have been described in the literature. So, going in temporal order, the orbitozygomatic approach developed by Dr. Hakira Huba in 1982 entails a very big craniotomy frontally. It allows a wide exposure and wide access for instrumentation, but it nonetheless is associated with poor cosmetic outcome, and therefore it requires aesthetic reconstruction. Anterior crinoidectomy, the approach by Donalds, is a relatively more optimal approach. It enables the surgeon to sort of identify and protect the optic apparatus. It enables an anteroposterior exposure of the cavernous sinus, and it allows the identification of the cranial nerves in the interdural part of the procedure. The Kawase, the anterior petrosectomy approach, is a very flexible approach. It's especially useful for medially extending lesions, but it nonetheless presents with complications associated with the drilling of the anterior petrous part of the temporal bone. So for this reason, these patients may encounter risks of postoperative damage to the intrapetrous part of the carotid artery, as well as potential hearing loss by hitting the inner ear. The translateral orbital wall approach is a relatively faster and less invasive variant of the orbitozygomatic approach, but it's only indicated for smaller lesions. Other variations, of course, the supraorbital keyhole enables exposure in full of the anterior fossa, but doesn't give access to the anterior portion of the middle fossa for cavernous sinus. The rotor-sig, as we said, is a more posterior approach, particularly indicated for the posterior section of the sinus, but of course it cannot reach the more anterior and lateral portion and the juxtacavernous region. Posterior petrosectomy, it's another variation very suitable again for the posterior fossa and the petroclidal region for the full exposure, but the trajectory is of course in conflict with the frontalis branches of the nerve. And the mini-tyrional is again another variation of the standard tyrional approach, but on the other side is associated with a very poor cosmetic outcomes. Transorbital approaches are relatively more new. They represent a direct and relatively avascular corridor to the anterior skull base. In particular, there are four main transorbital approaches, and the approach through the medial canthus is the one most suited for the approach of the cavernous sinus. So it starts with an incision at the conjunction between the skin and the conjunctiva of the orbit. It goes with periorbital elevation and the dissection from roof to top of the orbit to then allow for the burr holes for the cranium. Other endoscopic approaches are most suited for what is being described as the type 3 variation of the cavernous sinus. So those tumors with a lateral displacement, lateral growth with medial displacement of the nerves, they should be most suited to tackle the medial side of the lesion. They do present with the advantage of exposing the inferior part of the cavernous sinus and the superior orbital fissure, but they give a very poor exposure to the lateral wall, and this may represent a limitation for that. We next sought to address the literature concerning combined open approaches. So combined open approaches are associated with relatively larger meningiomas. They tend to involve the petroclidal region or other mixed sections of the skull base. In general, we included both anatomical studies and a small amount of case series and case reports. And the general outcome for patients present a wide and heterogeneous rate of postoperative complications related especially to the neurological, the cranial nerve deficits. Although it is worth noting that there is a very there is a very limited description in the literature for large case series. We only included a series of 109 extended patients, but the cavernous sinus meningiomas were just a fraction. And finally, the combined open and endoscopic approaches, they do present a relatively new avenue. We found just 2 instances that were just anatomical studies, so we do believe that extending the literature and the practice on the combination of the open and the endoscopic approaches could be a relatively new and much more promising avenue to the surgical treatment.
You're saying done simultaneously?
Yes, yes, exactly.
So is microsurgical and endoscopy, endoscope to visualize the corners of the surgery services is combined. It's more the endoscope as the tool.
Yeah, so this represents a relatively newer avenue. It's been tested on cadavers, but there is a relatively lack in the literature concerning the experience in real cases. So to conclude, cavernous meningiomas are relatively rare pathologies. They may present, despite the good the benign histologic behavior, with very severe neurological morbidity. Their management is mostly dictated by the anatomical relationship and the clinical outcome of the patient. So there are several techniques. They are combined both the open, the endoscopic, the transorbital. But the general understanding in the literature is that given the proximity to very crucial neurovascular structures, the more conservative we are, the better. So it's really important, nonetheless, to remember that there are open surgical approaches. They're very feasible. There is a growing body growing evidence in the literature that suggests that combined approaches, the open and the endoscopic, may achieve extremely good results with very low rate of postoperative complications. So
thank you. So you're chosen on your topic, I think what is, I would consider the most difficult neurosurgical approach. There's just, you're dealing with multiple cranial nerves, you're dealing with vascular structures, and it's all inside of a sinus that's full of blood. And it's a very difficult area.
Difficult to access.
And I've done them through orbital zygomatic approach, but they're all difficult. And you're still dealing with tumor that's attached to the dura. And how are you going to get that off there? If you're using a laser, you can cause thermal damage to these structures. This is a very, very difficult procedure, and often we have to leave a residual tumor. So, and like you said, conservative's better. You don't want to give a bunch of deficits, 5 deficits, cranial nerves. So.
I think the clinical example that Paolo showed demonstrate what is the CAP management of these tumors. And we learned in the last 20 years that we didn't have to remove completely. So most patients, if there is a very large tumor, let's say more than 2 centimeters, or there is a large, or there is important neurological deficit, you will approach to remove partially, and then you will perform, Gragnaniello surgery after. And the during this presentation, the case, this will be a very difficult case where, this patient is 70 years old, 72 years old. He has major balance issues because of that tumor that was removed, many years ago, like 30, 40 years ago. And he has presented actually 2 other meningiomas that he developed from that one was resected, and then another one to the gamma knife, and in the follow-up he presents with this. So this was motivated.
I also might say that gamma knife isn't, these tumors aren't that susceptible to gamma knife. also radiosensitive, so it's a tough,
Yeah.
procedure
It
altogether.